morning. I'm Dr. Richard Fine. I'm the Director of Education and Research at the Margaret West Comprehensive Breast Center in Memphis, Tennessee. Today we're going to be performing a cryoablation procedure on a patient that is 74 years old who has a luminal A, very small tumor of 4 to 6 millimeters in size. She's grade 1, ER/PR strongly positive, HER2 negative. We've offered her the option of a non-surgical approach to the partial mastectomy. The other treatments that we will offer her will be based on the same treatments that we would offer any woman of her age with this type of tumor. So she will be a candidate for endocrine therapy, and if she's interested, a candidate for radiation therapy, though we are not currently radiating patients with this type of tumor that are over the age of 70. This will be an office-based procedure. We're actually standing in one of my exam rooms. Patient will be awake without sedation, and this will be done strictly under local anesthetic. So let's take a look at the tray that we're going to set up for the procedure. This is a clean procedure, though we do try and stay as sterile as possible during the procedure. We use sterile gloves, sterile gel. We prep with betadine swabs and then towel off the area, sterile gauze. We have several syringes here. There's 1% xylocaine for local anesthetic, and then there is saline. And we use the saline for moving the tumor away from the chest wall or away from the skin. As the ice ball forms and grows, we want to protect the chest wall and the skin. So it's a pretty simple setup. Underneath the syringes here, there's actually a small 11-blade scalpel for making a skin nick. We usually try and use the nick that was used for the core biopsy for obtaining the diagnosis. All right, I'm going to clean your breast off with some betadine. And then in just a second, we'll put some towels around the area. So there's some towels. And what I want you to do is to make sure you keep that left hand down by your side. All right. And I just prep an area that's wide enough so that I can, as I decide how to approach the lesion, I have plenty of room to come in from a more lateral approach to keep the cryoablation probe parallel to the chest wall and allow me to make sure I have room above the ice ball to the skin and below the ice ball to the muscle. I've got some 1% xylocaine drawn up for local anesthetic. I start with a 27 gauge to raise the skin wheel, a little more comfortable for the patient. 25 gauge needle after that. And I'll show you how I will take local all the way down to the lesion and above and below it. Saline is for injecting later, as we might need to separate the skin or lift the skin away from the ice ball to protect her skin. We have cleaned off the transducer and using sterile gel. You can use an ultrasound transducer drape. I just feel like, especially with the lesion that we're going to be working on today, that we need as good a visualization as we possibly can have, and sometimes the transducer drape can distort the visualization. Okay, so I'm looking at a sagittal view right now, and when I did my biopsy note, I commented in the biopsy note that the clip deployed inferior to the lesion. I'm seeing the hydromark clip. And this is the transverse view. And this is the lesion right here, what's left of it. There's only about a 4 to 5 millimeter lesion to begin with, and the clip is just inferior to the residual lesion, as we see here. So I want you to freeze right there, okay? And let's, number one, measure from the top of the lesion to the skin. Right Nope. Right where I'm pointing. Keep going to the right, to the right, to the right. Nope. Too far. Back down. Slowly. Right there.
I want to talk here about your depth and
Okay.
what you kind of need.
So I want the top of the lesion to be at least 5 millimeters from, go straight up to the top of the skin and make it a straight line. Bring it this way. So the depth of the lesion is 12.3 millimeters. We would like a minimum of 5 millimeters because when we create the ice ball, we don't want to risk getting the skin. Okay, now you can save that. All right, now let's measure the transverse dimension from here. Keep going. No, you're going too far. Go down. Go down. Straight down. Stop. Go over. Right there. So the length in the transverse orientation is 4.8 millimeters. Now measure top to bottom of the lesion. No, of the lesion. No. Put your cursor right where that bottom, right where that is. Okay? And then go straight down. Stop. So the AP diameter is 3.8 millimeters. All right, now let's look at it longitudinally. Freeze, okay? And measure from here. Nope, go in, go in, go in, stop. Go, keep going, slowly, slowly, keep going. Right, no, too far. Back. Okay, 4.7 millimeters. All right. Now, as we get ready to inject numbing, one of the things that we will do is raise this off of the chest wall. We're not really going to have much of an issue with skin distance, but we are going to want to try and lift the ice ball off of the chest muscle. Okay, and the approach that we're going to take is a lateral medial approach. The lesion is at 1 o'clock, about 13 centimeters from the nipple, and our entry site is going to be more like 12 to 12:30, 13 centimeters from the nipple. All right, so here comes the numbing medicine. Okay. And because it's so deep, I'm going to come from the side over here. Doing okay? Any pain? Okay, good. All right, injecting local, creating a pathway down to the lesion. Local? I would say usually about 10 cc's to start the case. And if you can see that I'm creating a plane between the pectoral fascia and the bottom of the lesion. And then we'll put some local up above as well. I'm just going to make a little nick in the skin. And I'm going to actually use the nick that we used the other day for doing the biopsy. And we'll put the probe in just like we did the needle when we did your biopsy. Okay? All right, I'll take the probe. All right. So I'm going to approach the lesion fairly far lateral. so that I can also kind of slide up parallel to the muscle without actually going in the muscle. You guys see the tip of the probe? And that's the end where the lesion was. All right, I want you to freeze. So one of the things that we want to do is to make sure that the ice ball, which is going to be about 4 centimeters in length, is going to be positioned on both sides of the lesion itself. So what you do is, let's just say this was 6 millimeters, and you take half of that, which is 3 millimeters, which is the radius of the lesion, and subtract that from 20 millimeters, which is the half of the freezing zone, and that would leave you with 17. So what we want to do now is measure from the distal side of the lesion. So you keep going, you're right almost there. Go straight up, right there, and then go out to the tip of the needle. Keep going. Right there, which is 17.1.
Oh, I calculated about 1.75.
So I think that's about exactly where, as far past the lesion as we need to be. So usually the freeze is about 8 minutes of freezing, 9 minutes of thaw, 9 freeze, same thaw, and then refreeze for the same amount of time.
We're going to watch that width because it's an oval ice ball, so the width is really what we're going to monitor.
Right. As you can see, I've turned the transducer at a right angle, so I'm measuring the width of the ice ball as it develops. Because I'm not worried about the skin, but I was somewhat worried about the chest wall, I'm torquing up on the probe to pull the lesion and the probe away from the chest wall as the ice ball forms. Now, this was not an easy cryoablation to demonstrate on video because we started with a 4 to 5 millimeter lesion in greatest diameter, and the device that was used to biopsy the lesion was a small gauge vacuum assisted needle, and 2 to 3 samples actually removed most of the lesion. A hydromark clip was placed because I wanted to be sure that it would be well visualized right adjacent to the lesion and what was left of it. And that way, if the ice ball incorporated the hydromark, then I would feel confident that it was also incorporating what residual lesion was left, since it was right next to the hydromark. If we're dealing with a lesion that's more along the lines of a centimeter, it's much easier to demonstrate, the dimensions of the lesion. It's much easier to demonstrate the position of the probe in the center of the lesion and measuring the distance from the probe to the top of the lesion on 2 dimensions. Because what we try and do is to, on a 90-degree angle like this, or a sagittal approach to the Cryoprobe, we want to visualize the probe in the center of the lesion. So for example, if you have a 6 millimeter AP diameter of a lesion, then when you get your probe inserted in place, you want to be able to measure from the probe to the top of the lesion and have it be approximately 3 millimeters, justifying that you are in the center of the lesion. Any discomfort or pain or anything? So right now I am going ahead and also putting a little local in and making sure that the ice ball is not getting too close to the skin. Because of the shadowing of the ice ball, it's not always easy to be able to get underneath. But we did put quite a bit of local lifting the lesion off of the chest wall when we first got started. And I'll continue to torque up and hold it away from the muscle. Freeze. Measure the diameter of the ice ball. Go up. Okay, there. Okay, 2.5. All right, unfreeze. Any pain? Mm-hmm. All right, let's freeze there. And go ahead. Almost 3.
Now we're at 9.
Now we're at 3.1.
On the hip ball. Okay.
Freeze. .3. How's it going? Okay. You good? Mm-hmm. Okay. So now what we're doing is we're letting it thaw. Mm-hmm. And we do that for about the same amount of time that we did the freeze, mm-hmm. and then we refreeze it one more time and we're done. Mm-hmm. Okay? Okay. When I lift up like that, does that cause you any discomfort or sharp or anything? No. Okay. All right. Well, we are on the last leg. Okay? Almost there. We're halfway through our final freeze.
Oh, okay.
That looks more like it. Yeah, 3.2. Yeah, okay. Go down a little bit. A little bit more. Okay.
Okay.
Freeze. Down. Out. Okay. Straight. Come down because you're not straight. Come down. Come down. A little further. Okay, good. And straight out. All right. 3.68. And the same as the other. Go back to the wide view.
The length again is going to be good. Yeah. Capture the picture.
Okay. Okay. Probe is coming out. Wet a couple of these for me. Okay. I'm just cleaning off the betadine and a little bit of blood. with some alcohol. And then going to hold a little pressure. Then what we'll do is we will close the skin neck with steri strips, and you take some Tylenol, or Advil, whatever, if you have some aching. I don't think you'll need any pain medication. We never usually had to prescribe any, okay? So during the course of the procedure, the initial local anesthetic, including lifting the tumor off the chest wall, was, so 3 cc's, which was for the skin wheel and the initial superficial injection, another 10 cc's of local. And then during the course of the procedure, saline was 20 cc's, and then another 5 cc's of local. So total of 20 cc's of saline and 18 cc's of local anesthetic. And much of the local anesthetic was used for lifting the lesion off of the muscle and separating the skin from the top of the ice ball. The saline was specifically used for separating the top of the ice ball from the skin. All right, let's have a little steri strip. So how was the experience?
It was fine.
Yeah,
Great.
no pain or
No
anything?
pain.
Okay, good. So we have a patient that has a very small, favorable luminal A type tumor, and we have given her a non-surgical alternative to going for a lumpectomy or partial mastectomy. We will send you to see a medical oncologist, and the purpose of that is to discuss endocrine therapy, because your tumor was hormone receptor positive, and the endocrine therapy is helpful in that situation. Okay? All right?
Okay.
Okay.
Thank you.
You're welcome.